I'm Dr. Catherine Nichols. I'm a nurse practitioner at the Women's Wellness Clinic here at Karmanos. Um, I'm here full-time, and I diagnose and treat breast cancer and survivors, and that's kind of my forte. But I'm going to talk to you today about um, new cancer treatments and new developments in treatment and screening and guidelines. We're going to cover a lot of stuff today, so let's get started here. First thing first, can I ask, how many of you have had cancer? Almost everybody. Okay. Just kind of want to know who I'm talking to here. So, first, to understand what personalized treatment is, and we're going to talk about personalized cancer treatment, and that's one of the newest and latest things in cancer. We need to understand what cancer is. So first, talking about what cancer is. Normal cells, when you talk about a regular, just normal body thing, normal cells are programmed to live and die, just as we are, and that keeps our, what we call homeostasis going. Cancer cells are only programmed to live. They don't die, and they keep going and going and going, and they can, go to other areas of the body, and they take over normal areas. So that's kind of what cancer does. This is just a representation of abnormal cell growth. The top there kind of tells you about, normal cell division, and then that bottom part there kind of shows how cancer keeps growing and growing and it starts building into this mass and replacing normal tissue. And those of you that have had cancer can understand how that happens. These are kind of the basic different types of cancers that arise in the different tissues and blood areas of our bodies. Most cancers are kind of categorized into one of these areas. What causes cancer? Well, first and foremost, genetics, I guess. Maybe not foremost. Usually genetics is not a real usual way cancer is caused. It's kind of lower on the totem pole there. Second kind are behavioral factors. A lot of our cancers are caused by how we live and what we do. Smoking, exercise, diet, environmental factors, those are another cause, like radiation, secondhand smoke. Pollution now is showing things in our foods, hormones that have been added in our foods sometimes. That's being researched now. Viral infections have been shown and recently proven to cause cancer, and I'm sure you've heard of HPV, human papillomavirus, and that causes cervical cancer. Most cervical cancer is caused by HPV. This is just a more closer look at causes of cancer, kind of broken down into different ways that we are exposed. And kind of showing us our risks for developing cancer. I think that's remarkable right there. 35% of all cancer cases are caused by diet. So that really kind of makes us stop and think. Poor nutrition and poor in physical activity causes 1 in every 3 cancer deaths. So overweight and obesity raises the risk of 13 different types of cancer. Those are some things to think about there. So now that we understand what cancer is, let's talk about personalized treatment. Personalized treatment is treatment that's tailored to each individual. Recent scientific advances have allowed us to aim and tailor treatment to each individual and their specific cancer. Advances aim to create targeted treatments that are better at finding and destroying cancer cells and without harming the healthy cells. So this is done through the use of what's called biomarkers. Now, biomarkers are markers on tissues and elsewhere in the body that we can target And the way we target this is with drugs and chemotherapy, and it's kind of like weed killer. So you're killing the weeds and not the surrounding good grass, not the surrounding areas, not the flowers. Each patient is unique, and each patient has, different biomarkers. Each cancer type is unique. You may have different genetic mutations depending on the type of cancer. I don't know how many of you have had breast cancer and have ever heard of the BRCA1 and 2 mutations. Those would be biomarkers that are mutations that are genetically derived that can be targeted. Personalized treatment also limits side effects because it doesn't kill the surrounding normal healthy tissue. So how do we find biomarkers? Biomarkers can be found through screening tests, and screening tests usually are done through blood samples and tissue samples. So normally we have to get, either draw some blood and we can find the biomarker there, or we have to get a biopsy of the actual tissue, and that'll show the marker on the tissue. So biomarkers for personalized medicine are useful to detect cancer early, confirm the results of other tests and symptoms, determine if a cancer type will respond to certain treatments, measure response to treatment, and help us determine if a cancer may return after treatment. So they're very important, and it's really kind of the way that cancer treatment is going. It's not a one-size-fits-all any longer. So some examples of some biomarkers. Human epidural growth factor receptor 2. Like I said, I don't know how many of you have had breast cancer. You may be familiar with the AGR2 receptor. Herceptin is the drug that targets that, and some women that have the HER2 get the Herceptin when they're treated for their breast cancer. Epidural growth factor receptor, that's found in a lot of different cancers: colon cancer, lung cancer, head and neck cancer, pancreatic cancer. So even the fact that you have that receptor, and if we find that as a biomarker, is telling us, yeah, this is cancer, and that kind of confirms it. And then we go ahead and find out what kind. ALK is found in metastatic lung cancer. BRAF is usually found in melanoma. Those are just some more examples. There's lots of signals that cancer can be targeted to stop growth with. Like we were talking about the HER2 angiogenesis pathways, and what that means is angiogenesis is something that a cancer develops. When cancer grows, it makes its own blood supply. So it gets fed. It's like its feeding tube. And we have now discovered ways to stop that blood supply and to stop that feeding so the cancer will die. So that's what stopping the angiogenesis pathway is. Other antigens are, I don't know if you've heard of these, the CD20, CD33, CD53, proteasomes, Philadelphia chromosomes. You may be familiar with, like I said, if you've had breast cancer, the ER/PR markers, estrogen receptor and progesterone receptor markers on breast cancer. And those are targeted with things like tamoxifen or Arimidex, and those are pills that you can take that target those types of things. So, how do biomarkers work? This is kind of technical stuff, and I'll kind of go through this real quickly. Basically, treatment is aimed at both molecules inside and outside of the cell. So that's what the biomarkers are. And, monoclonal antibodies and the small molecule inhibitors are in and out of the cell. And that kind of tells us about, blocking the growth. This kind of shows you biomarkers act as a target for drugs to act only on those targets and not the viable normal tissue. So all of those little markers inside and outside of the cell, those are the biomarkers that we can now go after instead of kind of giving you a blanket treatment that kills everything and really makes you feel awful. So the future in cancer research and development really lies in clinical trials. So innovations to help prevent cancer, innovations to treat cancer, better personalized cancer treatment, and all of these things are done through clinical trials. How many of you were involved in a clinical trial? Anybody? You were. Okay, so you were. So you guys understand what that is. So clinical trials are laboratory research with tissue samples involving studies of the blood and cells from cancerous tissue to find clues about how cancer cells function differently. So this is kind of where things start. This is where new cancer treatment starts, right in a trial. And we have a number of trials here at Karmanos. Clinical trials are the only way to provide new treatments. Obviously, they have to be run through trials and see if they work. They involve lots of different phases, and we'll take a look at these. This is just kind of an overview of kind of 3 different stages, phases. This is typical of most clinical research. So that's how it happens. The green would be phase 1, the orange would be phase 2, and the purple would be kind of phase 3 or post phase 3. So that's kind of the typical timeline for true cancer research development. This is us, clinical trials at Karmanos. This is kind of how it's broken down here at Karmanos. Phase 1 is not usually aimed at a specific disease. It's just a clinical trial. Phase 2 is a focus on a particular type of cancer and evaluate how well the drugs work in that kind of cancer. Phase 3 is an actual where the participant is assigned to a group either using the drug or using a placebo. That would be the control group to see how well the new drug or the procedure works. Usually they're huge studies that take place, not only we are part of the National Cancer Institute. There's only 41 of us in the country, so we partner with other national cancer institutes like Mayo and Cleveland Clinic and MD Anderson to develop new cancer treatments and screening things. So that's kind of where phase 3 would be. After phase 3 is when it comes to the public and we can offer it and it gets FDA approved. Cancer prevention trials are another thing. Certain medicines, vitamins, minerals, supplements that may lower the risk of the development of cancer. So that's what cancer prevention trials are. Cancer control trials are with drugs to reduce the side effects of chemotherapy and other primary treatments. So you can see we have studies in every single aspect of these phases. And if you'd like to discover more or see if you can participate in any of these trials, you can call that Karmanos number or just email that email right there. You've got it in your packet, and someone will get back with you. On the Karmanos.org site, you can just type in clinical trials and it'll come up with some more information for you as well. If you become involved in a clinical trial, your rights are protected, and that's by law. So you stay anonymous. You have the right to be fully informed. You can drop out at any time, and they're worth finding out about, and possibly being treated. So, how do we prevent cancers? Well, 2 different ways, really. By making sure you get the recommended screening and by knowing your risks. There's new screening guidelines for almost every different type of cancer that have come out within the last year or 2 that maybe we should go over so that you know if you're on target and know your risks for developing different kinds of cancers. Let's talk about breast cancer first. Obviously, I'm the breast cancer person. So your risk factors, of course, being a woman, early periods or late menopause, having a child after 30 raises your risk, and being overweight. Screening guidelines, just being aware of your breasts, clinical breast exam annually, an annual mammogram. We at Karmanos still go by annually. Some of the literature recently has said every other year. The American College of Surgeons, the American College of Radiology, and the American Cancer Society all have said annually is still the way to go, and so do we. Genetic counseling, if you have a family history of cancers, especially breast cancers, on one side of the family, and we can test you for genes, the BRCA1 and other genes, to see if they exist in you, those biomarkers. We have some new screening techniques here at Karmanos that don't exist anyplace else. That's right. This one I'm just going to show you. I don't have a pointer, I don't think. This one right here is called a soft view machine. And what this is it's ultrasound tomography. It's a 3D image of your breast in ultrasound. You lie on your stomach and your breast goes through that hole. And your breast is in water. And the water conducts the ultrasound. Right now, we can't get an entire breast on an ultrasound. And when we look at things on a mammogram, on an ultrasound, it's kind of like looking at a flat plate. This is giving us a spherical view all the way around. This was developed here over the course of multiple years, and a company, it just got FDA approved within the last several months. Dr. Peter Littrup and his team are still running research on it, but it's been proven to be real effective. We're hoping that this might augment annual screening for women so that we don't have to get squished so often. You can just lay down. The second type of thing, these are all 3D images, is something called tomographic mammography, which is that top one. Okay, tomographic mammography is kind of what CAT scan is to X-ray. An X-ray is just a flat picture of something, right? CAT scan kind of gives you this whole big 3D view. That's what tomographic mammography does. It takes an X-ray and turns it into this big, huge 3D view of your entire breast and your entire breast tissue, so we can see everything more clearly. The third type is something called molecular breast imaging, and that kind of doesn't do it justice. Molecular breast imaging is comparable to an MRI. And as you can see, it's much like a mammogram. She's just standing there, and it's a little bit of compression. It's not as much as we do with even a mammogram. A radio tracer dye lights up if there's cancer. And we're the only ones in the area that have that. At least in the Midwest. I don't know if in the nation. So these are some of the things you can take advantage of at Karmanos that we're doing that nobody else is. Cervical and oral cancer screening, of course, your risk factors are HPV, like we said. That can cause cervical and oral cancer. Smoking, of course, is another risk factor. Screening guidelines for cervical cancer have changed over the last year or two. I don't know if you know this, women. Women who have had 3 normal Pap tests in a row can get screened every 3 years instead of every year. HPV testing is only every 5 years now, starting at the age of 30. Women under 30 don't get tested for HPV. The HPV vaccine is given to females. That's the guidelines between the ages of 13 and 26. And to males now, it's been approved. Males should be getting this as well between the ages of 13 and 21. It's 3 doses of the vaccine. So you'd get one now, you'd get one in 2 months, and then you'd get one 6 months after the first dose. That's how the HPV vaccine goes. Women over 65, if you've had no abnormal pap tests within the last 5 to 10 years, you can stop having pap smears if you choose. Those are the guidelines there. Of course, women who have had a hysterectomy can choose to stop having pap smears. It's recommended an annual vaginal examination, but there is no cervix to look at if you've had a hysterectomy. Oral cancer screening is still only done by inspection. We only take swabs and do kind of some more advanced things if we're suspecting there to be some oral cancer there. The screening is just kind of looking, and your primary care provider can do that. Ovarian cancer is a hard one, and you women may know that. Risk factors, early periods, menopause late. We consider late after 52. Never having kids, family history of breast or ovarian cancer obviously raises your risk. Screening guidelines, annual pelvic exams. Really, a transvaginal ultrasound isn't been approved, and most insurances won't cover that for an annual screening. That's usually only done if there's a problem or if there's a high risk. The CA-125 marker can alert us to something, but that also is kind of a general marker for other cancers as well. Genetic testing, of course, is another way to go. Colon cancer. Risk factors, again, high fat, low fiber diets, history of polyps, being overweight and inactive, and being over 50. So the screening guidelines, you can do this in 3 ways. You can get a fecal occult blood test annually. Do you know what that is? Those are those little cards. And you put your specimen on the card and you can mail it in, or take it to your doctor's office, and that's how that's done. That's done annually. Flexible sigmoidoscopy every 5 years. That's not done very much anymore. Colonoscopy every 10 years. Or if you have a family history of polyps, or you've had polyps yourself, the recommendations are every 3 to 5 years on a colonoscopy. So those of you that are 50 or over and haven't had colonoscopies, it's time to start. Polyps, they can just be just for no particular reason. Lots and lots of people have polyps, but it does increase your risk of colon cancer. A lot of times, your doctor will snip those off in a colonoscopy. Just did that. There we go. Prostate cancer. So, screening guidelines for men at normal risk starting around age 50. You should discuss the risks and the benefits of this with your doctor. PSA annually, that's kind of equivocal. Within the last year, the United States Prevention and Task Force has said there's no advantage on getting a PSA annually. However, many physicians and oncologists disagree with that. Something to talk to your doctor about. Depends on your risk, depends on who you are, and your lifestyle. African American men should start at the age of 45. African American men have a higher risk of prostate cancer than do Caucasian men. So if you have a family history, you should start discussing this with your doctor at age 40. Testicular cancer, of course, the risk factors right there. Testicular self-exam is usually the way this goes. Most testicular cancers are found by the man himself during self-examination. There really isn't a imaging or blood test to do this yet. So your doctor will do your annual exam with you as well. This is new with lung cancer. Your risk factors, again, smoking, environmental exposure, new guidelines and recommendations for an annual CAT scan if you meet these criteria. If you have a history of heavy smoking, which would be a pack a day, for 30 or more years, or like 2 packs a day for 15 years. That would be a heavy smoker. And you're between the ages of 55 and 74. You would qualify, and your insurance would cover a CAT scan every year. I would suggest that happens. Or if you're over 55 with a history of moderate smoking, which means 1 pack per day for 20 years, plus another risk factor, which would be, environmental exposure, or if you have asthma or something like that. So that's a new guideline, and I'm recommending a lot of my patients. Yes. Yes. No. Within the last, I think, even if you've quit up, how does that go? Up until 30 years. If you quit 30 years ago, 30 years or less, you still qualify. If it's been more than that and you still have that much of a smoking history, then, but yeah. Yep. So if it's, if you quit 10 years ago and you still have a heavy smoking history, you still need to get that. So, and your insurance will pay for that. And 2 of those, I guess. So, preventing cancer. So preventing all of these things from happening to us. There are, like we were talking about, vaccines. So just like we were saying with the vaccine for the HPV, there also is a vaccine for testicular cancer called Provenge. And that's new, and that was just approved, which is a nice thing. There's not many vaccines yet for cancer, but more and more are being developed. What they do is they target the immune system to destroy the cells if you have that already, and to prevent you from developing those. So other ways that we can prevent cancer are, of course, healthy lifestyles, eating a healthy diet, being physically active on a regular basis, every day, not just maybe once a week or once a month, and maintaining a healthy body weight are as important as not using tobacco and reducing your cancer risk. Eating healthy. This kind of gives you the healthy plate here, and I'm sure we've all seen that, right? Get moving. As little as 2 hours a week of physical activity can reduce cancer by up to 40%. I want to let you know that cancer deaths are 50% higher in obese men and 60% higher in obese women than they are in normal weight people. So this is huge. And our obesity epidemic is a big problem with our cancers and our cancer deaths. Strength training is important as well. Don't smoke. I guess everybody that says that too. Everybody that doesn't smoke. Smoking is responsible for 30% of all cancer deaths and is linked to 15 different kinds of cancers. It's not just lung cancer. It's kidney cancer and esophageal cancer and stomach cancer. Lots and lots of different cancers are associated with smoking. So if you are smoking, now is a good time to quit. So another way that we can live longer and be more healthy is to empower ourselves after we've been diagnosed and after we've had treatment to fully recover and beat recurrence. People who participate in their fight for recovery, along with their healthcare team, will improve the quality of their lives and may enhance the possibility of their recovery. It's been proven in studies, people that participate and that are empowered with and through and after their diagnosis have a longer lifespan than are people who are not active and are unaware of what's going on. Being patient empowered is about empowerment, asking questions, knowing your diagnosis, being a partner and not a passive subject, accessing resources online and with family and friends that have gone through the same kinds of things that you've gone through, making good life choices, and knowing who the new you is. The new you after your cancer diagnosis, and coming to terms with that and looking forward. Managing side effects is a major issue with cancer survivors. And you can take a look at some of that. The active patient is the most healthy patient. And you can manage a lot of ways your side effects. The emotional impacts of cancer are far-reaching. Distress interferes with your ability to manage your treatment, relationship, finances, and I've seen all of those things. Also, like I said, it decreases your length of life. Distress and anxiety that goes untreated. Distress and anxiety are very treatable. Some ways to deal with distress and anxiety. Get involved with support groups. Gilda's Club, wonderful place to go for all kinds of cancer, and to meet with people and to hook up with survivors. Improving your self-confidence, improving your physical health, and improving your psychological, social, and spiritual functioning, all is going to lengthen the course of your life. So life changes after treatment. Don't forget, you're still you. You didn't change, you didn't go away. You're still in there, and you're still you. You might have to search for a new normal, find new meanings in life, acquire stronger coping skills, and boy, my survivors really do. And I am inspired by them every day, every day. You develop greater insights in what's important, and kind of what's important to you in your life. New orientation to time, striving to live in the present. And giving back is a huge thing. A lot of my survivors, that's one of their number one things. They want to give back to the community. They want to share their stories and help others that are going through the same things. Looking to the future is a great way to stay healthy and to recover fully. Talking to your friends and family, don't be afraid. Don't be afraid to make plans, both financially, emotionally, and spiritually. More information than these things are in your handout. If you want to take a look at some of these websites, they're wonderful. Also, the National Cancer Institute is right on top, of which we're a member. Like I said, only 41 in the country. And I hope that's helpful. Thanks for coming. Thanks very much.